Hey there, this is Dr. Evan Osar, founder of Fitness Education Seminars, the movement-based solution to the healthcare crisis, and author of the Corrective Exercise Solutions to Common Hip and Shoulder Dysfunction. Thank you so much for tuning into this webinar. If you were on the webinar at Evidence-Based Fitness Academy a couple weeks ago where we had a small technical difficulty with the presentation, I apologize for the inconvenience and wanted to make sure you got a copy of the audio with the PowerPoint presentation. And if you were unable to make the call, then here's a copy of the webinar on improving hip centration for fitness, for function, for life. Let's get started. We know that hips are so important for so many functions in our body, including the most important, which is gait. The hips are important for not only dealing with ground reaction forces, or the force coming up from the foot into the body, but also in force production to propel us forward, as well as force reduction to reduce the effects of gravity, our body weight, and external loads on our pelvis and lower extremities. And we also know that there's an increasing number of hip issues, especially centered around this issue called femoral acetabular impingement, or FAI. And we're seeing an increased number of FAI surgeries. In fact, I got to observe one of the top hip surgeons here in Chicago a few months ago doing 4 surgeries on relatively young individuals for FAI issues. So we'll talk about why we're seeing so many more of these issues, as well as what we can do as fitness professionals to help deal with these issues. And we're also seeing early joint dysfunction, meaning that we're seeing more and more individuals with earlier joint dysfunction and even getting hip replacements at an earlier and earlier age. And not just from congenital issues, but more importantly, how these individuals are using their hips through daily life and also exercise, and what we can do as fitness professionals to be part of the solution and improve function in the hips of our clients. So the hip joints, what do we know about the hip joints? Well, we know they're ball and socket, so they are highly mobile, which requires a significant level of stability. So when we start to think about that mobility stability model, we hear that the hips are usually mobile and we need to create mobility of the hips. But most of the reason that our clients lose hip mobility is really because they have a lack of stability. And the lack of mobility is their way or their strategy for increasing stability. We'll talk more about that as we go along. Stabilization comes from 3 different regions, or 3 different areas. One is the depth of the acetabulum. The acetabulum is deep and it surrounds the head of the femur, so it creates a nice socket for the femoral head. It also comes from the myofascial structures. So of course, the myofascial structures that cover the hip joint are some of the biggest and strongest muscles in the body. So that provides us incredible stability for this mobile joint. And the ligaments and joint capsules also provide an additional support. And the myofascial structures actually attach and blend with the ligaments and the joint capsule. Going along with the ligaments and joint capsule is the labrum, and that's where we're seeing more and more of these labral tears, also related to the FAI we just talked about, because of how people are using or misusing their hips. So we'll talk about also why does that happen and what we can do about it as fitness professionals. When we talk about the centrated hip, what we're really referring to is a position of the hip where the femoral head is centered, or what we call centrated. Centration just means a position of optimal axis of rotation, where the joint surfaces of the femoral head within the acetabulum are optimal for loading. And we have a co-activation of the functional synergists, so all those muscles around the joint work together in unison, in concert, to maintain optimal position and that optimal axis of rotation. So there's a balance of forces around the joint, which allows us efficiency in both stabilization and movement. When we have a decentrated hip, or we lose co-activation of these functional muscle synergists, myofascial synergists around the hip joint, that's where we start to run into trouble. So the decentrated hip is really that loss of joint centration, or that loss of an optimal axis of rotation. And it's usually due to increased posterior and lateral myofascial, what we call gripping, or overcontraction, myofascial overcontraction. The nervous system is overcontracting the posterior and or lateral fibers around the hip complex to create stability. And we have an anterior shear of the femoral head, increased anterior shear of the femoral head within the acetabulum. And that's directly leading to a lot of these acetabular issues, as well as that femoral acetabular impingement that we talked about, and the development of groin injuries and early degenerative changes of the hip complex. So the most common cause of hip issues is that loss of joint centration, where we have that anterior femoral head glide syndrome, where the femoral head drives forward within the acetabulum. That leads to many of our common syndromes, as we discussed, including femoral acetabular impingement, FAI, labral tears because of the impingement and tractioning of the labrum, and of course, groin adductor and even hamstring issues because they start to overcompensate, the hamstrings and adductors overcompensate for that poorly centrated and poorly stabilized position. And this sort of just feeds into the perpetuation of this hip dysfunction. So why do we lose function? Well, there's three primary categories: neurodevelopmental, trauma, and learned behaviors. And we're going to go through these briefly. Neurodevelopmental. Vojta, who is really his work, he was a medical doctor out of Prague in the Czech Republic and Germany. He developed, or he worked with cerebral palsy children, and what he saw was like many of these children had poor neuromotor skills. So these children developed pretty consistent and characteristic motor patterns. And what he noticed is in adult populations, many of these characteristics were the same or expressed very similarly, meaning that many of our adult populations that don't have CP weren't born with optimal neuromotor development. And that's where we start to see a lot of these clients that present to us, and you may teach them a squat pattern, and each time they come in, their squat pattern looks terrible. It's like you're teaching them exactly the same pattern like they were coming in from day one. We're trying to teach our clients how to stabilize their scapula, and their scapula are just still winging off their thoracic cage, even despite our best intentions. A lot of these clients are part of that group of individuals that belong in that neurodevelopmental category, where 1 in 3 individuals, 1 in 3 adult clients, or 1 in 3 of us aren't developed optimally neurodevelopmentally. It doesn't mean we don't function. It doesn't mean that we can't achieve a decent level of function, but these are not going to be your professional athletes or high-level athletes or high-functioning individuals. These are generally going to be the clients that have more postural issues, more movement issues, where it's harder for them to have a body awareness or get their body to do the things you want them to do. It doesn't make them bad individuals. It doesn't mean they can't learn or get to an improved level for them, but they just have neuromotor systems that are less developed or less evolved than the rest of us. However, we can do a lot as fitness professionals to help these individuals. The second and one of the most common causes is trauma. Both the acute trauma, like a fall, a sporting injury, a car accident, where we have a significant trauma that directly impacts our hip. Also, there's surgical causes of trauma, where we have abdominal surgeries, low back surgeries that directly impact and affect how our hips function. And that's another reason we start to get into some of these hip gripping patterns, is we're trying to create hip gripping, or these individuals are trying to create hip gripping to create a more optimal core stabilization strategy. And also we're going to look at briefly the chronic and repetitive traumas, and that's really our habits, our clients' habits. How do our clients sit? So I have a question for you. How do your clients sit? Do you actually look at how they sit, or do we just look at how we've been taught that we think they sit? So look at these two individuals here. One, a kid sitting in a chair playing his video game or working on a computer, and this adult client sitting in a chair working on his laptop. What position are these clients sitting in? Are they anterior tilted, are they neutral, or are they posterior tilted? Both these individuals are very representative of how the majority of our clients are sitting in their chairs every single day. So what's your answer? Anterior tilt, posterior tilt, or neutral? Most of our clients are actually sitting in, most of our clients are actually sitting in a posterior tilt. You can see the pelvis is tilted backwards, and they're in lumbar spine flexion, both these individuals. The thorax is behind the base of support, the base of sitting support, and then both of these individuals are in a posterior pelvic tilt. So what about this client here who presented to me with hip tightness and low back pain? What do you see there? Are our clients really in an anterior pelvic tilt? It sure looks that way. So how do we determine if she's really in an anterior pelvic tilt? Because oftentimes our eyes will lie to us. We have to prove it. So let's look at a Thomas test, because if this client is really in an anterior pelvic tilt with an increased lumbar lordosis like it looks like, she should have real tight and short hip flexors and probably a tight and short psoas, as we've been taught. But when we look at her, put her in Thomas test, look what we see. An over-lengthened hip flexors and an over-lengthened psoas, and her psoas was testing weak. So how do we see this posture here, but then get this result as we go into our assessments of these postures? Well, most of our clients are sitting in a posterior pelvic tilt, like this, my client here, who's got a flat lumbar spine and a posterior pelvic tilt. The other thing, going back to this client of mine, if you look at where this extension really is occurring, it's not in her lumbar spine, it's actually at the thoracolumbar junction. When we lose control, when our clients lose control of the thoracopelvic canister, or how the thorax sits over top of the pelvis, they start to get that thoracopelvic extension. And we start to lock the posterior aspect of the diaphragm. We start to lock with the attachment of the psoas, where it fascially blends into the diaphragm, where the transverse abdominis fibers are wrapping around to the posterior aspect to blend with the diaphragm and with the psoas. And also the QL comes up from the deep fibers, come up and blend fascially with the psoas, the diaphragm, and the transverse abdominis. So these muscles are key to stabilizing that thoracolumbar junction. And when we have poor respiratory habits, when we have poor stabilization strategies, then we start to get this thoracolumbar extension, and we get shutting down of the deep stabilization system. And that leads to a lot of these changes that we see in our clients' hips. So again, the loss of optimal alignment of the TPC is actually one of the greatest causes of our clients' hip dysfunction. So again, remember, you must prove to yourself that your client's in an anterior pelvic tilt or a posterior pelvic tilt, and not bias yourself based on what we've learned through our education. Learned behaviors. What are the cumulative effects of these patterns? Our habitual ways we exercise. Well, barbell squat, great exercise. However, it has very poor effect on our spine. If you see this client here is a typical hyperextension of the thoracic spine, flexion of the lumbar spine, and she's starting to go into a posterior pelvic tilt in a squat pattern, even though it looks like she's in pretty good alignment. She's actually reversing the curves of her spine, overloading the low back, and creating hip and pelvic dysfunction. These clients doing the hip hyperextension, really, none of these clients are actually getting pure hip extension. You can see she's maybe 10 degrees of hip extension. Most of the extension is coming out of thoracolumbar junction. Cues that we give our clients, like when they're doing deadlifts and squats, squeeze your glutes, drive your pelvis up or forward. We see that again, the hyper extension at the thoracolumbar junction. And if you were to see if you can tell through my pelvis, posterior pelvic tilt, and if you palpated my femoral head, is being jammed forward by this poor cueing during deadlift and squat patterns. So a lot of the exercises and how we cue these exercises are directly leading to some of our clients' hip dysfunction. And again, we can just make small and easy modifications to change the effectiveness of these exercises, as well as change the trauma that we're causing and creating in the hip joint by some of these patterning and cueing. And of course, how we cue our clients has a dramatic effect on their hips. Like tightening your core, we'll see how the tightening your core will actually create a posterior pelvic tilt. As you pull your abs in, that creates a flexion load on your spine or on your trunk, and it also creates that sort of lumbar flattening, and or if a client is able to maintain neutral spine, it just creates an overcompression of their trunk. Squeezing your glutes, so driving that pelvis forward, directly drives the femoral head forward if the client does not have optimal hip centration or ability to centrate their hips. And pulling your shoulder blades down and back will lock up that thoracolumbar region, inhibit your breathing, and again, drive more of that hip dysfunction. So the result of these cues, they lock the thorax, especially that posterior aspect of the thorax, posterior lower aspect of the thorax, and which creates cervical lumbar spine hypermobility, which then creates a need for increased stiffness and stability elsewhere. Hips are a great region for us to compensate for lack of stability in the cervical and lumbar spine and the thoracopelvic canister. So what's the effect of this dysfunction? Well, when we lose optimal control, we have a compensatory stabilization strategy. Once we have a compensatory stabilization strategy, then that directly relates into how we move. So we compensate in how we move. Kind of like my client in this image to the left, how she loses control of her pelvis and that hip centration. She overactivation, you can see the overactivation of her erectors, and she has huge erector tone, and she ends up hyperextending through that thoracolumbar junction. That leads to our pain and orthopedic injury. So again, this client has neck and shoulder discomfort because of how she's locking up her neck and shoulders to create stability through that thoracopelvic region. And then again, perpetuation of dysfunction, so this whole cycle continues. And again, we can easily change the cycle just by changing small things about how we cue and the exercises that we're using with our clients. So what's a myofascial response to this dysfunction? Well, if you look at the two systems, and again, this is sort of an arbitrary categorization of how our muscle systems work. However, there's a direct effect on how the muscle systems get affected by trauma, stress, inflammation. And the research has proven that almost every region of the body that they've researched, the neck, the low back, the knee, when there's joint inflammation and or injury, we have a direct effect and influence of the deep myofascial system versus a superficial myofascial system. So in general, the deep myofascial system leads to inhibition. So we have stabilization and movement dysfunction based on or secondary to inhibition of this deep myofascial muscles. So the muscles and fascial structures that sit right next to the joint and are responsible for stabilization. Then that also leads to proprioceptive dysfunction. So our brain has less ability to identify and feel where the joint position is. So we have a loss of the efficiency of motor control. So what happens to the superficial myofascial system? Well, in compensation, it becomes overactive. And that's where we get a lot of the spasm and muscle guarding, also referred to as gripping. So we get overcompression of the joint structures, and usually not in an optimally centrated position. And then we have a challenge, our clients have challenges with the inability to turn these muscles off, especially at rest. Meaning, like, when you have the loss of the deep system, your body has to compensate, so you start to overgrip the superficial myofascial system. And what happens is the clients have a hard time turning the muscles off when they should be turned off, like sitting, like when they're sleeping, while at rest. And this is where our clients often get problems from sitting all day long. Not because they sit all day long, but because these superficial muscles have so much compression on their system and they're unable to turn them off. So part of our strategy to help these clients with hip dysfunction is to teach our clients how to turn these muscles off. And this is what we're talking about with the GRIPPER'S syndrome. You can see this client here that came in, an athlete with SI joint pain. You see the myofascial gripping he had on his bilateral hips, and you can sort of see the pocket or divot that's created in his lateral hip region. And you see this client at the airport that I saw, and she's got the posterior lower atrophy of the glute maximus. When you overcompress the superficial fibers, the hamstrings, and the lateral aspect and the superficial fibers of the gluteus medius, you start to get these pockets and divots where the client is not using and not able to centrate the hip optimally. So the effects of gripping on the anterior hip position is the short-term effect is you're going to get femoral acetabular impingement, those groin, adductor, hamstring injuries that we talked about from muscles overcompensating, especially those adductor and hamstrings, and that's why our clients start to have strains in those areas. And then this is an MRI of a 22-year-old baseball athlete that I was seeing with this exact presentation, and he ended up having to have surgery for a torn labrum. So again, we can help these clients hopefully prevent injury and surgery, but we can also help these clients when they come out of surgery to help these clients develop more optimal patterns. If our clients start gripping for long periods of time, like this client of mine in this x-ray right here, this is a client who had a C-section, so her strategy for improving her lumbopelvic stabilization from her abdominal inhibition was to overgrip her posterior hips. She created degeneration of her hip. So the femoral head was jammed forward in the acetabulum when she first saw me, and then actually the compensations from this right hip created left hip problems, so she's had one hip replaced and now she's going for another hip replacement. So if we can get these clients early enough and teach them how to optimally centrate their hips, we can save a lot of these clients from having to go to surgery. So how do we do that? So there are three principles that we created of the integrated movement system, the three principles to improving function. And we adhere to the principles because they apply to every population, whether you train and work with senior population, whether you work with pre and postnatal clientele, whether you work with professional athletes, it doesn't matter. These principles apply to every single population. It's not based on methods like kettlebells, CrossFit, powerlifting, Tabata. Those are methods. We apply the principles, and you can apply the principles to whatever method you work with. So the first principle we have is respiration must be normalized. We must help these clients improve respiration because that helps set up optimal stabilization. Our second principle, centration. We've been talking about that all along. Centration essentially is maintaining the optimal axis of rotation. So we see this in this image here. If we're looking at sort of a bird's eye view, here's the acetabulum. The femoral head should sit relatively centrated within the acetabulum. When we have too much posterior lateral myofascial gripping, the femoral head is jammed forward, and we get that anterior wear and tear, anterior and superior wear and tear, and that's where the majority of our clients have degenerative changes, anterior and superior on the femoral head from too much of that posterior gripping. And of course, if we're looking at the spine, that must also be centrated. So again, one vertebrae on top of the other vertebrae should stay relatively centrated, and we should not have excessive translation and or shear. Centration has two components. We must be able to stabilize or keep that femoral head maintained within the acetabulum, and then we must be able to dissociate the femoral head from the acetabulum. So again, during a leg drop, during a squat, we must be able to make the hip and pelvis move independent but under neuromuscular control. So again, we must stabilize the femoral head within the acetabulum and then be able to move the pelvis over the femoral head or the femoral head around or within the acetabulum under neuromuscular control. Once we tell our clients how to breathe right and how to centrate, then we teach them how to integrate it into the fundamental movement patterns: squatting, lunging, bending, rotating, walking, pushing, and pulling. So again, three principles: respiration, centration, integration. It doesn't matter what method you use. If you apply the three principles, you will help your clients improve their hip function. So how do we improve hip centration? So we're going to look at alignment of the TPC and lower extremity, so the thoracolpelvic canister in the lower extremity. We're going to teach our clients how to breathe right. We have plenty of videos on our website at Fitness Education Seminars to demonstrate how proper breathing looks. Coordination, we're going to coordinate alignment and activation of the core with lower extremity function. We're going to develop optimal control and then execute the fundamental patterns of squatting, lunging, and rotation. So first, how do you assess for the loss of centration? Well, in some clients, it's going to be real obvious. You're going to see it. You can see that hollow or the divot, and you can actually run your hands down the lateral thigh and feel that hollowing or divot in the lateral aspect behind the greater trochanter of the femur. Or you can palpate for it. You can see this image here. The client has a forward pelvis position. Femoral head sits way far forward within the acetabulum. I'm palpating around the greater trochanter, the front and back, and you can sometimes get a sense of the femoral head within the inguinal canal if your palpation skills are optimal. You can see the difference here where the femoral head is forward within the acetabulum, and here where it's more centered and centrated within the pelvis. So it should be sort of centered. The greater trochanter should be lining up almost within the midline of between the ASIS and PSIS. Okay. So when we're trying to centrate the hip, it's so important what happens down at the foot. So we're going to look at the ankle-foot reflex, and the law of irradiation basically says that if we set up the foot right, the effects of foot centration will irradiate up the entire lower extremity. And actually spreading of the metatarsals stretches the interosseous muscles, or the muscles in between the metatarsals, and that creates this reflexive extension reaction in the body. So rather than having somebody extend up, lift their chest up, squeeze their glutes, squeeze their hamstrings, squeeze their back muscles, if we set up the foot and lower extremity properly, the extensor muscle group, the extensor chain, will actually turn on the way it's supposed to, and it starts at the foot. We have to teach the client how to get that foot tripod and spread the metatarsals out and create long toes. So we want to make sure the client can get this and achieve this optimal position. So again, it's often beneficial to have the client in barefoot or bare feet, so you can actually see the foot on the floor and teach the client proper mechanics in their bare feet before you put them back in their shoes. So when we talk about the ankle foot tripod, what we're looking for is stability and balance between the 3 points, the 3 main points of the foot. And that's weight underneath the first metatarsal phalangeal joint, the fifth, and the calcaneus. This does not mean that the foot floats on these 3 points, but the majority of the weight should be borne through these 3 points. We should have weight across all metatarsal heads, but the majority of the weight should be on these 3 points. Many of our clients have big, thick calluses around this area of the foot, and they don't ever get the big toe down on the ground appropriately. Or they'll have no calluses under this portion of the foot, but they'll have huge calluses and bunion formation out here because they're not supporting themselves appropriately through the foot tripod. Once we get the foot tripod, we want to think about activating the interossei muscles, activating the abductor hallucis, flexor hallucis brevis, sorry about that, to create optimal activation and connection from the foot all the way up the lower extremity to the hip joint itself. The foot feeds into the hip, and the hip feeds down directly into the foot. Once we get foot aligned and the lower extremity aligned, so the hip, knee, ankle, and foot are aligned, now we have to teach a client how to release some of those overactive myofascial structures. So in this image here, I'm having the client palpate her posterior hip and her anterior hip. She's softening through the anterior hip, and I'm having her teach her brain how to let go of this myofascial compression. So in many of these clients, we'll do some myofascial release, we'll do some muscle activation, whatever strategy you use to get the client to get their hip in a better position, soft tissue-wise. So use those strategies that you already know how to use, but then you also have to train the nervous system, because the nervous system will only go back to the patterns it knows. Teach the client how to monitor themselves for proper alignment of the hip, the knee, ankle, and foot, as well as how to let go of especially those anterior myofascial structures as well as those posterior myofascial structures. So I'm teaching this client how to sit back into her hip with proper alignment of her hip, knee, ankle, and foot. Now you take that into your squat and lunge. Teach the client how to maintain that thoracolpelvic canister alignment, so the thorax over top of the pelvis, and line up the hip, knee, ankle, and foot, and then sit back into the hip while squatting and lunging, whether you're doing forward lunge, backwards lunge, lateral lunge, or a transverse plane lunge. Teach them how to sit into their hip and maintain that thoracolpelvic canister alignment. Then load them up in whatever pattern you like to load them up with. The hip hinge is another great and fundamental pattern, as it teaches dissociation of the pelvis over the femoral head. Again, we're going to maintain that thoracolpelvic canister alignment. We're going to align the hip, knee, ankle, and foot complex. We're going to teach the client how to dissociate the pelvis over top of the femoral head, again creating that functional length through that posterior chain, as well as teach them how to eccentrically control that sort of forward bend position. So again, we're trying to create that pivot around the femoral head, and we want to make sure that this pattern is optimal, because this is the pattern that feeds into a lot of the reaching patterns, the deadlift patterns, and a lot of the functional patterns we're going to have our clients do. So again, a great pattern to teach optimal mechanics, dissociation, as well as maintaining the joint centrated position. The bridge is another great pattern to teach joint centration. Again, very simple pattern. However, it's not simple to do it optimally. We want to make sure that the client can maintain a thoracolpelvic canister alignment, long spine, and a properly centrated hip position. You see this image here to the left, the femoral head has gone forward because I've over-clenched my glutes, and it's hard to tell, but I actually have that hollow and divot in my glute, and have thoracolumbar extended. And that's why a lot of these hip thruster type activities will actually create and perpetuate hip dysfunction, because we are decentrating the femoral head within the acetabulum, perpetuating a lot of dysfunction our clients already have. So we want to make sure that the client can maintain a centrated hip joint position. The bridge is not a great pattern to teach hip extension. It's a great pattern to teach hip extension from the floor to the neutral position, but not from this neutral position beyond, because now there's nowhere for the hip to really go but anterior within the acetabulum. Lunges, pushing a sled, those types of patterns are much more optimal for teaching hip extension mechanics than the bridges. And like I said, the bridge pattern done improperly or overloaded by putting weight on the pelvis will directly perpetuate a lot of hip dysfunction. We also have to look at the cues we're giving our clients for their pelvis and their hips. So we want to cue our clients not to pull their abs in, because this will often result in a posterior pelvic tilt, and also not teach them to squeeze their glutes. Relax the glutes, relax the abdominal wall, activate lightly, think long, and then sit back in the hips. The glutes will do what they have to do when you're lined up optimally, when you're centrated optimally, when you're breathing optimally. the hips and glutes will do exactly what they need to do. Similarly, we don't want to teach our clients to squeeze their glutes. We want to teach them how to relax and center, sit back into the hips. The glutes will function the way they're supposed to function when the thoracolpelvic canister is aligned and the pelvis is in good alignment. So, take-home keys. Understand the central nervous system response to dysfunction. Most of our clients with hip dysfunction actually have unstable hips, hence the reason they're over-gripping their hips. Not only do we have to teach our clients how to relax out of that gripping, but we teach them how to properly stabilize, how to centrate the hip, and how to teach them how to use the myofascial components around the hip optimally. We want to adhere to the principles. The 3 principles: respiration must be normalized, we must achieve joint centration, then we must be able to teach them how to breathe right and centrate their joints through their fundamental patterns of pushing, pulling, squatting, lunging, bending, rotating, and gait. And always, always, always keep doing what you're doing, empower your clients, make a difference. Again, you can make small changes that make dramatic changes and help your clients achieve their functional health and fitness goals. If you're looking for further resources, you can access all our free video clips at fitnesseducationseminars.com. There's over 100 videos on improving joint centration, breathing, applying the fundamental principles that we talked about, the 3 principles, to corrective exercises. And we created fitness educations, my wife and I created fitness education seminars to give you guys up-to-date corrective exercise strategies for training the general population. So sign up for our free e-resource, Fitness Insider, and you can also get a copy of my book, if you do not have it, on corrective exercise solutions to common hip and shoulder dysfunction if you're looking for additional resources. And again, for further training, if you're looking for further training to help your general population clientele, we created Integrative Movement Specialist certification, and this is an advanced training for the fitness professional that works with the general population. My wife and I work mostly with the general population. While we see professional athletes and professional dancers, the majority of the people we see are the general population. The clients that majority of us see that have common hip and shoulder dysfunction, common core dysfunction, coming out of post-surgical, have chronic aches and pains, chronic postural dysfunction. And what we do, what we've created is a certification designed specifically for working with these individuals to help you guys develop the skill set, but help our clients achieve their health and fitness goals. So again, you'll discover the solutions, practical solutions for your most challenging client issues, so they become, and you become, the solution that your clients need, want, and will pay for. Again, this training is selective and highly advanced training, so we only have a small group setting. It's limited to 10 individuals. It's split up over 4 weekends and supported by manuals, video, and phone conference. So if you're looking for more information and more resources and further training in principle-based training, feel free to check out more information at fitnesseducationseminars.com, the Integrative Movement Specialist certification. I want to thank you so much for watching this webinar and hope that it has helped you remain informed so that you can become the corrective exercise specialist your clients need and want. This is Dr. Evan Osar of Fitness Education Seminars, providing you with the solutions and strategies you need to become the movement-based solution to the healthcare crisis. Take care. Thank you so much.